You're all set.
All right. So, speaking of my interest in fetal therapy, I have to go do a fetal transfusion at about 1 o'clock. So, this may be a little bit abbreviated, but I think it'll still give us time to cover the topic. Um, so, whenever you read about venous thromboembolism, this guy's name comes up, Virchow. Just in medical school, I thought, oh, great, just another one of these German physicians that I don't know anything about, and why do we have to learn about him? Um, they all kind of look alike. And I thought, man, if I grew a beard and got some wire rimmed glasses, I might start looking like this guy here in a few years. But he really made this rather amazing observation that patients who developed deep venous thrombosis typically had one or more of these three factors involved: stasis, hypercoagulability, and vessel wall injury. And so diving into each of these three, I think, helps us understand how our pregnant patients in particular are at risk for this complication. So endothelial injury or vessel wall damage is damage to the inner lining of the blood vessels, often caused by trauma, surgery, hypertension, or inflammation, which can initiate the clotting cascade. Stasis of flow, or a slowed circulation, is blood that is stagnant, usually due to immobility, such as bed rest. See this frequently patients do transatlantic flights, or for us, the weight of the gravid uterus pressing down on the vena cava. And then hypercoagulability is an abnormal blood constitution, a condition where blood clots more easily than normal, often associated with either cancer, pregnancy, dehydration, or genetic factors. Leiden factor mutation just being one common example. So in pregnancy, there's an increase in multiple procoagulant factors, including von Willebrand's factor and fibrinogen, in addition to those listed. Also, there's a decrease in natural anticoagulants. So the body has this amazing fine-tuned balance between forming blood clots and preventing blood clot formation. So free protein S activity declines, and there's a resistance to activated protein C that increases. Also, fibrinolysis, or the body's ability to break down a clot, is suppressed. These changes are hormonally driven, influenced by both estrogen and progesterone, which enhance clotting factor synthesis at the beginning in early pregnancy. What about venous stasis? Well, this actually begins as early as the first trimester, likely from progesterone-induced venodilation, and peaks around week 36. As the gravid uterus gets larger with a growing fetus, the inferior vena cava and pelvic veins can be compressed, leading to obstruction of venous return. Decreased mobility of our patients later in pregnancy further contributes to this stasis problem. And then what about vascular endothelial injury? Delivery itself could actually be an insult, whether vaginal or cesarean. Even the delivery of the placenta can be a risk factor. It causes direct vascular trauma to pelvic vessels. Cesarean delivery, assisted vaginal delivery, postpartum hemorrhage, puerperal infection amplify this component. There's clearly a temporal risk profile, meaning that with each subsequent trimester, the risk goes up. So it's doubled in the first and second trimesters, ninefold higher in the third. And this surprised me when I first learned about it. And I think patients need to be really highlighted that the first, especially the first week, but the first 2 to 6 weeks postpartum are actually the highest risk time up to 60, 80-fold higher risk compared to the non-pregnant state. Many of our patients think, oh, good, I've delivered, I'm home with my baby. Maybe I can quit sticking myself with this needle and get off these medications because I'm up and moving around. And it's worth just reminding them that actually this is the highest risk time. And please, please, let's keep you on this medicine for another 6 to 8 weeks. ACOG recommends that every obstetric patient undergo a documented venous thromboembolism risk factor assessment, either preconception or an early pregnancy, and then a reassessment on hospital admission. So I'm going to walk through just sort of these 3 broad categories of risk, and we'll start with high-risk thrombophilias. So you probably all have heard of these. So you can have either no abnormal genes, 1 abnormal gene, or 2 abnormal genes for many of these factors. When you have 2, it's called homozygous, and as you would guess, having 2 bad genes is worse than having 1 or none. And so homozygous factor V Leiden is considered a high-risk thrombophilia. The same is true of homozygous prothrombin gene mutation. And then if you just have a single gene of either one of those 2, you're considered a compound heterozygote. And that's just as bad as being homozygous for either one individually. Fourthly, an antithrombin deficiency is considered a high-risk thrombophilia. And so for all 4 of these situations, pharmacologic prophylaxis is recommended regardless of whether other risk factors are present or not. So these are the 4 major risk conditions. Lower risk thrombophilias that do not carry quite as high a risk of forming a blood clot include the heterozygous forms of factor V Leiden and prothrombin gene mutation, as well as a deficiency of protein C or S. So for these 3 conditions, prophylaxis decisions are individualized and based on the presence of additional risk factors, such as a family history of a blood clot, significant obesity in the patient, a known likelihood of being delivered by cesarean section, or some other condition that leads to a period of prolonged immobility. So deciding whether or not to use medication in these situations should involve consultation with either MFM or hematology. And then lastly, if you have a patient that has a prior history of a significant blood clot, they may require some adjusted dose medication during pregnancy if that event is occurring in the current pregnancy. So somebody who has a DVT or a PE in a current pregnancy is going to require heparin therapy. Women who have a history of a prior event or history of recurrent thrombosis are candidates for both antepartum and postpartum prophylaxis. Prophylaxis means they're on a lower dose of some form of heparin, not fully anticoagulated. And one little sort of carve out for this is a patient who maybe developed a blood clot for what's called a non-recurring condition, meaning it happened in the past, isn't going to happen in the future. This is like maybe they were in a car wreck, broke their leg, were in a cast, and they formed a blood clot because of that. Now they're totally fine. They may be able to be managed with a recommendation for prophylaxis in the first 6 weeks postpartum. Remember, that's the high risk time, especially if they're being delivered by cesarean section. So they may not need it for the whole pregnancy, but they still need it postpartum. So there are clearly diagnostic challenges to working up a pregnant patient who's manifesting symptoms that are suspicious for VTE or PE. And there's a couple of reasons for this. One of the very helpful tests in a non-pregnant patient is the D-dimer assay, but this assay is almost always elevated in pregnant patients. Pregnancy itself causes an increase in D-dimer levels. And then there have been reported cases of false negatives, meaning patients who actually have PEs can have a negative D-dimer test. So this test is not super helpful in the pregnant population. I remember one night being on call and a emergency room physician from an outlying hospital called me, and she'd already worked up the patient for signs and symptoms of a PE, and the whole workup was negative. She even got a CT scan. They couldn't find a PE or a blood clot anywhere, but the D-dimer test was positive. And so she wanted to transfer the patient to me just because this laboratory test was abnormal. And I said, well, it's almost always positive in a pregnant patient. And she's like, well, still, the test is positive and I don't feel comfortable keeping her here. I said, but you've already done the workup and your workup is negative. Yeah, but the D-dimer is positive. So it was like the easiest thing for me was just to go ahead and accept the patient and you just shake her hand and send her back home. But the ER physician was just deathly afraid that something was going to happen to the patient because this D-dimer test was positive, which it almost always is in pregnant patients. To exacerbate the diagnostic dilemma, the typical symptoms that lead you to think about thromboembolic disease are symptoms that you see in almost every normal, healthy pregnant patient. So either a shortness of breath or a perception of being short of breath, an increased heart rate, swelling of the legs, leg pain. All of these can occur in completely healthy, normal pregnant patients. So one of the problems is that the established risk prediction models used in the non-pregnant population, such as the Wells criteria, the modified Geneva score, or the simply read D-dimer protocol, have not been validated in pregnant women. So this leaves clinicians without a well-established framework for estimating pre-test probability. So what's the likelihood your patient has a PE? Knowing going into it that the risk is actually very low because it only occurs in about 0.3% of the population, meaning that most women evaluated for symptoms suspicious of a PE will not have a PE. There is this one intriguing algorithm called the pregnancy adapted years algorithm, where they looked at patients with whether or not they presented with one or more of these three signs. Clinical signs traditionally thought to indicate a DVT, coughing up blood in the sputum, or just a clinical assessment as PE is the most likely diagnosis. And then they use rather strict D-dimer thresholds, less than 1,000 if none of the criteria were met, or less than 500 if one or more criterion were met. And they were able to go to the next slide. They were able to, using this, to only fail to make the diagnosis in 0.21% of patients, and they were able to reduce the utilization of CT pulmonary angiography in 39% of patients overall. So they dramatically reduced the need to do this somewhat invasive imaging study while not incurring a huge risk of undiagnosed PE. There's the reference in the New England Journal if anybody would like to read that study. So these tests that traditionally we use to make the diagnosis of a PE certainly involve ionizing radiation, either the CT angiogram or VQ, ventilation perfusion scanning. The CT delivers higher maternal breast radiation, but it's widely available and people are more familiar with it. The VQ scanning delivers a lower breast radiation, but a slightly higher fetal radiation dose, not as widely available. People aren't as familiar with it. Both of these modalities come in well below the concern about radiation exposure to the fetus. So that's concludes my presentation. This is just a reference to on the internet, one of our Prisma web pages has a nice little sort of overview of this topic and has a very functional sort of decision tree to help you decide which patients require which sort of treatments. The next presentation Dr. Campbell will give will dive much deeper into treatment. So, but this is, I find, a very useful thing. And then ACOG has a technical bulletin on this topic, which is also extremely useful.